So we're going to do a few things, and we're going to start off with some of various and sundry approaches. So we're going to go from that to balloon kyphoplasty. We'll talk about tumor ablation, and we'll also talk about spine jack after the balloon kyphoplasty, so in that order. So what we'll do here, first off, we will go a little bit north or superior. I'm going to show a few different approaches. All right. So let's come back. It's fine. So call it tilt. Great. All right. And so first of all, we're going to start off with just a simple transparticular approach. On this, we're going to go from, well, I'll show you on the screen. So from here, we will go, no camera, it's fine. Do it like this. From here, we will go, from this point, 1 centimeter up, 2 centimeters out from the 10 o'clock region of the pedicle. So we have 10 o'clock and 2 o'clock for the left and right respectively. Centimeter up, 2 centimeters out. I'm using the beveled needle. We'll come down, we'll make contact with the 10 o'clock region of the pedicle. And we'll go to a 30-degree angle and we'll hammer that in. And one of the things about the bevel that I like is it's directional controlled. The other thing is you have to really make sure and get purchase on the outside of the pedicle. So if you're not getting purchase, you turn the directional point of the needle away, and then you start off like that. So now we're getting purchase, going directly into the pedicle, and we come down. And the only real rule about this is before you violate the medial wall of the pedicle, so you see the tip of the needle coming there, you have to make sure you're in the posterior portion of the vertebral body. So at this point, we're going to go lateral, take a view. And if you just follow that simple rule, 10 o'clock and 2 o'clock on left and right respectively, you go down at a 30-degree angle, tap, tap, and if you don't violate the medial wall of the pedicle until you're in the posterior portion of the vertebral body, you'll never make a mistake. And so we see we're not quite there, which is, it's actually good. So we're about 3 millimeters away from the posterior wall, and we're not quite toward the medial wall of the pedicle. So the posterior wall of the vertebral body is just anterior to the needle tip. So we're going to come back around, and I'm going to show you why I like the bevel and the directional capability. So we're about 3 millimeters away from the posterior wall. We're also about 3 millimeters away from the medial wall of the pedicle. So we'll take a shot here. So we're equidistant. So it kind of means we're in the middle of the pedicle. So I'm going to go down, and before I transgress the medial wall, because we're approaching that, and it's getting very close, and we're right at the medial wall here, the needle tip. So I'm going to turn from the bevel sharp point facing away from me to facing to me, and watch what happens. And it will give us about 2 or 3 more millimeters of distance there, and we will go down. And now we'll take another lateral look, and we'll find ourselves in the posterior portion of the vertebral body wall. And that is the transparticular approach. A transparticular approach is tried and true. This is something that will give us reliable access to the vertebral body, and see we're just past that margin of the posterior wall. So, transparticular approach. Okay, what I'll show you now is the perpendicular approach. Just back around.
You can. Yes, you can.
And the perpendicular approach is the same as the transparticular approach, okay, except the starting point is farther out. So a line that goes from ipsilateral superior to contralateral superior vertebral body corner, one width of the vertebral body, right there, you go from one width of the vertebral body out here, and that lateral portion is my start point. So I'm going to make an incision right at that point, And if we can see on this line right here, we can see our original start point here is the transparticular. Our second incision here is the periappendicular. It's along the exact same trajectory, it's just farther out.
Doug, can you use the X-ray and scalpel to show that trajectory on X-ray? We saw it on camera.
Absolutely.
There you go.
Our start point is here for the transparticular. For the periappendicular, it's out here. And so what we'll do is we'll start out here, and we will have the same type of trajectory, and we're starting farther out. So what we're going to be doing is we're going to be accessing this just in front of the pedicle. And so when we get down here, I'm going to take a view and arc about 20 degrees toward me. 15 or 20, either one is fine. And so
now, Doug, when you're lining these up for the level of treatment, are you getting orthogonal view, AP lateral?
Always orthogonal, yeah, absolutely. And what I'm doing here is this is to show where we are. So on the X-ray, the tip is just anterior, you can go back AP, to the pedicle, and it's just above the equator of the 50-yard line. So this is not a transparticular approach because that needle tip is not going through the pedicle. It's going anterior to the pedicle, just above the equator. And this is also somewhat where the medial branch of the dorsal ramus lies. So I call this a twofer. So if you can hit the medial branch as you go in, you denervate the posterior elements. And this is something we try to ablate with radiofrequency energy, cryo, however you want to do that. Mechanical ablation with endoscopy. But you go straight in, and this is anterior to the vertebral body. So this does not go through the vertebral body. And here's the AP shot of this. And we'll take it on in. And because this doesn't go through the pedicle, the centimeter to 1.2 centimeter of bone, the tube of bone that is the pedicle, you can rock arm this and you can move it around because it doesn't go through the pedicle. Let's go lateral. Your chance of rocker arming that off and fracturing it is essentially zero. So, and also because it has a wider start point, you can really get medialized and get to the center of the vertebral body much more easily than you can with the transparticular approach. So we're already in the vertebral body, and to medialize that, I'm going to medialize it with the directional capability of this needle, and I'm going to drive it more toward the center of the vertebral body. And we're getting toward the center. All right, background AP, and you can see the trajectory of the needle is no longer a 30 degree, it's more like a 45 degree angle when measured as compared to the walls and the floor. So this is in the middle on the lateral, it's on the middle on the AP, and this is a very quick, easy approach. We kind of went through all that and we were able to tag the center of the vertebral body. So this is a way to medialize and get more medial reproducibly. And that is the periappendicular approach. One more, I'm going to ask you to go 45 degrees toward you, has a long name. It's called the Modified Inferior In-Plate Extrapedicular Approach, otherwise known as the Extrapedicular Approach. And so you'll need to have these tools in your armamentarium. So I'm not good enough to have just one approach and to be able to do this reproducibly. I'm also not able to see through Tyler. I actually have to ask him to move. And so, just kidding, thank you, Tyler. So this is our start point for the Modified Inferior In-Plate Extrapedicular Approach. It's 45 degrees off midline in the lumbar spine, 30 degrees in the thoracic spine. The start is just above the inferior end plate. If you go anterior to that, that's big red and big blue. If you go posterior to that needle tip, that's where all the neuroforaminal structures lie, and that's where the descending ventral rami go. So these are motor nerves, important real estate. If you go up to the 50-yard line, halfway up the vertebral body, that's the radicular artery. And that can and will bleed, and so you don't want to hit that if you can avoid it. Sometimes it is hit, but the bleeding, although it can be aggressive, stops fairly quickly. It's not something really to be worried about. But these are all the safe zones, and if you align the safe zone and you put the safe zone right there, and you mind, oh, perfect, thank you. And you mind those safe zones, you can drive it in and stick your thumb in the vertebral body and not cause any problems. And so we're headed right where we want to go, right just above the inferior end plate. And it's a little tap, tap, check position. I'm gonna go a little bit anterior. All right, we'll come back. Let's do an AP view from that. And this is a different view, and if you're not used to seeing this, this can throw you off a little bit. This is very useful for severe vertebral plana. It's very useful for getting around hardware, and this is exactly where we want to be. So let's go. I'm going to drive it in just a little bit on the AP, and then we'll go lateral after that. So, all right, good show. Let's go lateral. And this, if anything obstructs your way, if you have a 4-5, 5-5 pedicle screw in the way, if you can't see the pedicle because you can't, your tumor has obstructed the pedicle, if you have something in the way, if you have severe vertebral plana, if you want to put something big in the vertebral body and you can't fit it next to or in the pedicle, this is a very good way to do it. So here we have it in the mid and anterior portion of the vertebral body, and this is a lateral view. Let's come back around to AP.
Doug, this is showing up really well.
Great.
Could you go back to the bread and butter transparticular approach? We didn't have radiology up and running to see the landmarks that you were talking about, and now we do. There you go.
So mid on the AP and mid to anterior portion on the lateral is exactly where we want to be. So that's an ideal approach. So Neil, what we'll do is we'll go ahead and do a balloon kyphoplasty. And so we'll have Laura and Diana help out here. And we have a kyphoplasty set up, and I will do that balloon kyphoplasty with the transparticular approach. And so we'll start out at our typical centimeter up, 2 centimeters out, and let's come caudal a little bit like that, caudal tilt to sharpen the end plates up. So the end plates aren't quite as sharp as they need to be in this L2 vertebral body. We come a little caudal, and by magic, they sharpen up.
And Doug, you're often doing these on an ambulatory basis, so you're using a spinal needle to establish the anesthetic tract before entering the
all the way down to the periosteum, and that's part of the real key about doing this. If you establish and you numb all the way down, you can really do justice to the patient. So I'm using the needle technique with the bevel. It's a single bevel, so this has directional capability. The arrow is pointing this direction. It's a single bevel. It's beveled like this, and it tends to steer away from the face of the bevel. This is a bi-beveled needle, and this has a bevel on both sides, on the top and the bottom. So it tends to steer like this. And we'll go centimeter up, 2 centimeters out from the opposite pedicle. And on this one, we'll start at the 2 o'clock position, and we'll go a little farther out than that. And our start point will be about right there. And we'll start on the other side. So what we're going to do is we're going to drill, and then after this, and then we're going to balloon. And probably we should have the cement mixed or in the process of mixing, because it won't take us very long to get there. Transparticular approach, centimeter up, 2 centimeters out. Make it look as symmetrical as possible, because you gain style points for appearance. And before we violate the medial wall of the pedicle on the patient's right side, we're going to go lateral, and then we'll make sure we're in the posterior portion of the vertebral body. And one of the tricks that you can remember if you have 2 needles in and you don't know which is which and you can't recognize the tip, by the shape of the bevel. You can always pull one of the stylets back out of the cannula to make sure that you know that the purple handled needle that we're driving in is the one that we're going to see on the lateral view. So we have here, we're just past the posterior wall. So we're going to drive that in, and looking very symmetric. We're going to drive the other one in a little bit, and then I'm using the same track as I had before. So we'll stop right there.
Now, when you're shooting these laterals, you usually have the vertebral body being treated in the center of the field?
Yes. I'm not being
parallax will
overly
suffer.
fastidious about it.
Yeah.
A radiologic technique, because Victor's doing an awesome job. Drill, and we drill to within 3 to 5 millimeters of the anterior wall. And we don't drill closer than that because we have to remember that this is curvilinear. And if we drill too far, we can be in no man's land and be out the side of the vertebral body. So we have drilled, and now we're going to balloon.
You commonly anesthetize as you go forward?
Yeah, and sometimes if you have a lot of pain, people have pain from marrow changes, pressure changes. What I'll do is I'll inject lidocaine directly into the vertebral body, and that anesthetizes the nerve, the basovertebral nerve, and you get appropriate anesthesia. And remember, lidocaine is something that we use and inject intravenously all the time for cardiac arrhythmias. So just make sure you don't inject too much. More than 17 cc's of 2% lidocaine is about as much as you want to avoid getting lidocaine toxicity. Lidocaine toxicity is characterized by tum numbness, and you'll have a little bit of confusion, followed by delirium, followed by worse. And so we're lined up pretty well here, and I'm going to inflate one of the balloons. We have a pressure gauge here, so we're going to turn the pressure gauge on, and we will start.
In the orthopedic literature, putting Novocaine, lidocaine, into a fracture is called a hematoma block.
Yeah.
And it's used for all extremity fractures before they are aligned. So this is a fracture in the axial skeleton instead of the appendicular skeleton, but the anesthesia works the same way. So as the balloon reduces the fracture, or the expansion device like spine jack reduces the fracture, it will be painful because you're moving the fracture fragments, you're moving the periosteum. So if you have it anesthetized, you'll be able to do this as an office-based procedure without general anesthesia. If you don't have it anesthetized, the patient will be uncomfortable.
So I stole that idea from orthopedics, Neil.
Good move.
My wife says I hadn't had a new idea since the 90s, but I do steal other ideas very well. So I'm blowing up the balloons bilaterally here on both sides. You can see the pressure gauge. These are Express, let's go back, AP2, and they are rated to 700 PSI. Functionally, these are nylon balloons. You can blow them up. They're rated easily to 1,000 PSI, no problem. But the FDA rating is rated at 700. And so we will see where we are, and these are looking shockingly pretty good. We didn't check the AP view before I started doing this just for time's sake, but we knew because our trajectories were appropriate that we were right in there. And this is what's called the kissing balloon technique. I mean, the balloons are butting themselves up in the center, and you're able to get maximum balloon inflation. So the maximum balloon inflation is, you're at the point where, number one, you corrected the fracture, you've accomplished that goal. Number two, the balloons are at their maximum inflation, and these are low compliance balloons, so you blow them up past whatever the content they will take, and they will burst. And all you can, if they don't burst, there's no elastic recoil. The patient's insides don't explode. So there's virtually, fluid's not compressible, so you do it by feel. It goes from the pressure that you can see on the gauge and the pressure you can feel in your hand by turning the syringe to loss of pressure. And this is an excellent balloon inflation pattern. I'm going to deflate these by triggering.
Hold on just a second, Doug. Let me point something out to the fellows that what you see with both of those balloons is the lateral aspect of each balloon goes beyond the medial border of the pedicle. And so the maximum stability and strength of a reconstructed vertebral body is this exact picture, where the balloon and the subsequent cement goes to or slightly beyond the medial border of the pedicle on both sides. So the central vertebral body is now maximally stabilized. And this vertebral body is ideally reconstructed the way Doug has it, with these kissing balloons kissing in the center and the outer circumference of the balloon underneath the AP view of the medial border of the pedicle. So this is perfect placement for cement augmentation.
A while ago. Yeah.
Thanks, Doug. Go ahead.
Yeah, good. So we're hooking up the cement to this, and this cement and the cartridge is X speed. That's okay. We can do one at a time. Do we have two mixed?
There's one box of cement.
That's okay. We'll do one at a time. So I'm going to put the stylet in the other needle, and we will inject. And so this is out of the field injection. Go ahead and trigger that. And this is water in here that will pull up. And we can see the cement being injected in the vertebral body. Now we'll flip to lateral and monitor the injection on the lateral.
When doing cement injection, Doug, do you usually use a lateral view?
Always. So we're going to flip to lateral, and we know that that's going into the path of least resistance, which is the pathway of the balloon. And this is also X-speed cement, so this is a quick-to-dough, mix-and-go cement. And it comes out at about, X-speed comes out at about 500 to 600 Pascal seconds in terms of viscosity. It's got about an 8-minute working time. And so fairly good control. And we're injecting one side. I just connected the second one, so I'm going to inject.
An important take-home point of cement augmentation is do it in the lateral position.
Yes.
Because 1 out of 4 of the fractures will have a characteristic that will allow a leak to occur. And if a leak occurs anteriorly, laterally, left or right, it doesn't make any difference. If the leak goes posteriorly, that's where the neural structures live, and that's a very big and important problem. So when you see cement going into the posterior third of the vertebral body, as Doug is loading it from front to back, be ready to put the brakes on, because that's danger zone.
And part of this cement delivery system, the CDS, is what we're using here. So the CDS is characterized by a trigger, and this is hydraulic. You can see the water in the delivery system here and here. You can see the cement is going in with the plunger. And the CDS is a quick release valve. So if it's going and there's built up pressure and you want this to stop, you just trigger this on the back and the cement flow stops immediately. So we're getting pretty good cement flow. You could just trigger here, and then the release valve is here. And we can see bilateral with the cement going in, plungers, and the hydraulic system. So we'll take a look lateral, and we're going to inject a little bit more cement in, because more is better in almost everything in life, except for taxes. But this is, our goal here is between the pedicles, in plate to in plate, for maximum stability of the vertebral body. The amount of cement that you need to put in here is between 15 and 20% of the non-compressed level. So we're just going to continue, and this is a really beautiful cement fill, isn't it? Boy, that's very good. Even a blind squirrel finds a nut sometimes. So we're going to trigger that off, and this is really quite a good cement fill. I'm going to disconnect here, and we're going to put our stylets back in, and we're going to take an AP shot to see what it looks like.
One of the evolving features of cement augmentation is when the French originally came up with vertebroplasty, which is using a syringe to directly inject cement. It was very thin and very fluid-like and not very viscous. Since the curing of cement is exothermic, if you provide heat, those are terrific AP lateral pictures, Doug. Great job.
Thanks.
If you provide heat, you can accelerate the cement hardening And that lowers and diminishes the likelihood that the cement will extravasate out because it's thicker putty. If it's very thin, as in liquid, it can readily extravasate. And you'll see it showing up in veins, you'll see it showing up outside the vertebral body, you'll see it showing up in the disc space. If it's thicker, it has a less likelihood of doing that. So the cure time is usually 10 to 15 minutes, but you can accelerate that by adding the sterile water, hot water, dipping the reservoir in it. But you just have to be careful that when you accelerate, it may end up hardening in your insertion device, but you'll learn how to do that as time goes on.
And we'll need all the tips and tricks we can, especially for very fragmented vertebral fractures and tumor-involved vertebral fractures. And speaking of neoplastic fractures, we're going to show you the OsteoCool device. And this is a chicken breast on our tabletop, and we have a vertebral body that is, if we could turn the camera there, a vertebral body drawn on this. And after the access is to the vertebral body here, we are going to plug in the water-cooled probes, and we're going to do RF ablation of the anterior portion of this. And so the chicken breast is just designed to change colors so you can see the ablation zone. And this is the OsteoCool. These are the OsteoCool probes. And we'll do a bilateral access. Pull this a little bit, this way, so we can see.
Table's right behind you.
And then the probe will fit, and it has a press fit on either side. And you can see the probe will go all the way to the anterior portion of the vertebral body. Press fit on the other side. Same thing, you can see the probes, and then we'll go ahead and turn this on. And we'll start our next demo, and we will turn this on for however long that this calculates out that we need to burn. Typically, it's in the range of about 9 to 15 minutes, depending on the impedance of vertebral body size, the size of the probes, et cetera. So it's a little bit variable. Okay. Yeah. One of the other things that we should go over really quickly is the Kyphon Assist. And if I could have a camera to the tabletop. So this is a diamond-tipped needle, and this is a point that has multiple bevels, and this is very sharp on the end. This is a bibevel, and so this has a bevel on the top and bevel on the bottom. As I explained earlier, this is a single bevel as a point with one bevel. And if we pull this out, as an example, a conventional needle, it's blunt. The cannula is blunt on the end. So if we pull the other one out and we remove the stylet, this is also blunt, but it has half of the cannula carved away. So what this is designed to do is this bottom part is designed to fit toward the inferior portion of the vertebral body typically, and the balloon expands right here and expands by virtue of the backstop. This is the back of this Kyphon Assist cannula. And so this is a directional balloon capability. This has the ability to get your balloon to go superior. If you have a superior end plate fracture, you need to aim it that way, and vice versa, or just whichever way you need it to go. If the balloon needs to go medial, you put the outer wall, the backstop wall of the cannula laterally, so direct this medially. So this is called the Kyphon Assist. I'll rotate it around so you can see this. It's directional capability of the balloon. And this is definitely a nice advancement. This is a Medtronic device. Okay. All right, we'll use this. We're going to keep burning, and we have about 13 minutes and 6 seconds. And I'm going to go ahead and go on to the last demo that we have here is the spine jack. So Amanda will give me the introducer needle. The introducer needle is a typical 11 gauge needle. And this is it. And we're going to use a transparticular approach. And so I'll probably use just go just above where we were, so come up superior a little bit, very good. And so we'll start off, this is transparticular approach, centimeter up, 2 centimeters out, and making a incision. So the spine jack is a different device. It's an expandable titanium alloy implant. This was developed in France and was popularized and brought to the market by a company called Vexum. And this is a different approach. As you'll see, instead of the 10 o'clock and 2 o'clock approach, I'm starting very flat. So this is more of a 9 o'clock and 3 o'clock approach. So we want it to be flat because we also want the skis of the spine jack to be parallel to the fracture. And so we're going to advance this transparticular approach, and it's a very flat approach, and I'm going to try to get toward the medial portion of the vertebral body. So I'm going to start here, and then for time's sake, I'm just going to go ahead and start on the other side so we can go lateral one time.
So Doug, the difference between these two devices, between a balloon device, which gives circumferential elevation and expansion, and the directional spine jack, which gives mechanical instead of hydraulic elevation.
Exactly, and the mechanical is, for the spine jack, it's fairly profound. The ability to generate force with this is what really separates this from other devices. This demonstrates a lifting force between 500 and 1,000 newtons. So if I put it under your heel, it would lift you off the ground. So this is a fairly profound lifting force. So we'll take a lateral shot there, and we're starting at 9 o'clock and 3 o'clock, and we'll check our depth. And if we're in pretty good depth, we're going to drive it medially, place a K-wire, and then over the K-wire, we're going to have a rotating reamer. And I'll show you the difference between that technically and a drill. So on the lateral view, we are just, so let me see which is which. Okay. It's a little bit short. Can we come back around AP? I want to show you guys the right way. I know we do have a little bit of room to play with, especially with our beveled needles, but I want to show you the correct way to always avoid injury. So we're going to flip our bevel around. I have 3 more millimeters, and we're going to go right up to the wall. Same thing here, bevel around, have a few more millimeters, right? And we're going to go right up to the wall. Now let's go lateral.
So by changing the bevel, you're deviating the introducer away from the medial border of the pedicle.
Yes, and you know the pedicle, the donut that you're seeing, the oval, is around the waist of the pedicle. So we probably are already in the anterior portion of that vertebral body, just anterior portion of the pedicle into the vertebral body. We probably don't need to do it, but that's part of the way that you can keep safe and part of the margin of error that you have for this. So I'm right at this point in time, I'm going to take the stylet out and put the K-wire in. I'm going to do this on one side so you can get the full view of this. So this will come in and set right there. And always twist as you pull out. This bone doesn't like shear. It's very resistant to compression, distraction. And over this, I'm going to put a rotating reamer. And so this reamer is very sharp on the end. So this is self-tapping. It's also fluted and has the ridges on the side are also sharp. So this is not really necessarily a drill. So it has sharp edges, self-tapping, and this is a very aggressive tool. It's also size matched. So this is size matched. We have a blue on the handle. We know this is a 5/0 spine jack. And this portion right here, we also know whenever we get it into the vertebral body, which I'm going to start right now, we'll be able to see where the final size and resting place of the implant will be. So we'll go ahead and turn it all the way toward the front part of the vertebral body over the K-wire, making sure the K-wire doesn't advance. If it does, you grab it with a coker and bring it back.
That's a critically important thing to remember, is that the K-wire not advance. So you want to watch this in the lateral, because if the K-wire advances, big red and big blue are out the front of that vertebral body. And as the reamer goes through bone, bone can get stuck in the cannula hole, which will bind the guide wire and cause it to move forward as the drill moves forward. So you want to watch it very closely.
All right, so I'm going to put this in place. That looks pretty good. We can see the sized matched distal tip of the reamer. We'll put it up toward the anterior portion of the vertebral body. And I'm going to remove the K-wire. At this point in time, I want to take an AP shot, and we're going to check our medial lateral dimension to make sure we're okay there. And then once this is the case, we can have a template to clear out any bone shards, and we're at least to midline. We're slightly across midline. So what I'm going to do is I'm going to back it up just a smidge. So where we'll be in really good position. And then I'm going to place this acrylic plug after I take the reamer out, leave the working channel in place. A little bit more, thank you. And the acrylic plug is to stop the bleeding as we go to work on the contralateral side. All right, so we can see the plug and the tip, and I'm going to just go ahead and go back lateral. So I'll place the K-wire through. I'm going to remove the cannula, same thing on this side. And then we'll go down with the reamer, and then we'll place the implants. Okay.
So the biomechanics of the implant is based on a thing called a scissor lift. A scissor lift is something that's employed in all of the ports in the U.S. and around the world to transport freight. It lifts freight up, those storage boxes. Boeing uses a scissor lift to lift painters up to the side of the fuselage so they can paint the aircraft. And these skis on this device are the effector component of the scissor lift.
All right. So I'm going to pull the working, the reamer out of the working channel. We'll go ahead and go with the implant. So this is a 5.0 spine jack. The blue on the distal tip here is the jack itself, and this deploys coincident with the handle. So this will, I'm going to move the handle here. So the handle's up and down here, and the jack will deploy in the same direction as this handle. So I'm going to go ahead and insert this in, and we'll see the jack in the lateral view here. I'm going to press it toward anterior portion about 3 to 5 millimeters from the anterior vertebral body. And I'm going to take the acrylic plug out. We'll put the other implant in. And I'm going to deploy the right side. And so they're right, almost overlapping each other, which is okay. We want to get the maximum amount of lifting force. And whether the handle is up or down, depending, it doesn't matter. It deploys the similar distance, superior and inferior, up or down. And so we're going to deploy like this and like this, as long as this is deploying perpendicular to the end plate, pressing up against it. That's all we need. So I'm going to start here, and there's going to be 2 or 3 turns in the butterfly handle. Let's go ahead and do that 2 or 3 turns. Keep on going. And we can start to see the spine jack start to lift. Keep on 2 or 3 more turns. See it start to lift there, and we'll do 2 or 3 turns on this side.
You can see the skis expanding away from the center.
2 or 3 turns on this side.
You can see the ski.
2 or 3 turns on either side. Go ahead. Fantastic. By all means. So there's 13 turns to completely deploy this thing, and we're going to go ahead and go all the way because it looks awesome.
Do we have an example of the device that could be put into the camera's view?
Yes, I bet we do. And so once we go to a hard stop, if you hit the hard stop, it goes all the way to a hard stop. And what we'll do, we'll take a picture of it. And very nice, very symmetric. Then we'll back off a couple of turns. And then once we do that, it relieves the pressure. And then we'll unscrew the colored knob. And that's 10 turns to do that. And then when we unscrew the colored knob, we'll resist the urge to hold on to this handle because that's not any use for them. So we'll take this and we'll pop it off like this. Good. And once we pop these off, now it's going to be ready for cement installation. All right, so let's see what we have here in the lateral view. Very good. And so this is cement called Striker HV, and this is what we'll do. Do you have another cannula? Perfect. So we're going to inject on one side then the other. So we're going to put, as a blocker, we're going to put this one in here to block it, and we're going to inject. We're going to inject on this side. And this is an automated mixer, and this comes out, go ahead and hold that, at about 800 Pascal seconds. This is very, very thick, viscous cement, and it's nice. And this has a collar, it locks on here. So we'll go ahead and just give it a couple turns, and we'll be able to see this as cement goes in. Very nice. Okay, it fills the area where the spine jack, we'll hold up there. And we'll come to the other side, and we'll kind of swap these out. It fills the area of excursion where the spine jack lifted, first of all. And then it will start to fill around the anterior portion of the vertebral body in kind of a horseshoe shaped. It's a way, the natural tendency of the cement flow. So we'll get a little bit more cement on the other side. Okay, hold off right there. And so I want to kind of take an AP shot since we haven't looked AP yet. And we've done that just for the sake of brevity. We don't want to take forever at this, but this is something that we always want to check in the AP and lateral shots before we deploy, after we deploy, and as we're doing the cement fill to make sure we have adequacy of cement fill. So that's very good. If anything, we might be slightly to the right of midline, which is fine. So in that case, we'll inject more cement on the patient's left. So at this point in time, we're going to switch out. Let's go ahead and go back to lateral. As Dr. Schonard says, we always inject cement on the lateral. And you can see it's right under the implant. Both the superior portion of those skis are right under that superior end plate. And there's about 1,500 newtons of lifting force with the combination of those two jacks. All right.
And as the cement hardens, it controls the spine jack devices so they do not rotate and they remain ideally positioned and solid.
All right. That's pretty good right there. And we always see how much we have cement proximally too. We can always see the amount of cement that comes here, the amount remaining. And this is, we have about 3 cc's remaining. And this, we've injected about 8 cc's roughly in here, which is a pretty good amount of cement. But that's enough to do the job. 15 to 20% of the non-compressed level, if there's a single mistake that a lot of people make, is in not injecting enough cement. So that's the single biggest error that I see. You want to be able to treat the incident level fracture, you want to be able to fill it, and you want to make sure that you have enough permanent stabilization in that vertebral body to stabilize it over time.
Doug, can you show the fellows a deployed spine jack so
Yes.
they can visualize it on the camera?
So we're going to take these out and take an AP shot. I'm going to take one more shot lateral, Victor, before you come around. I'll take a lateral shot there. And as we take an AP shot, I'm going to go ahead and deploy this. This is a 5/8 spine jack. This comes in 4.2, 5.0, and 5.8. And this is a 5.8 spine jack.
Great job, Doug.
Thank you.
Really showed up well. If we get a look at that deployed spine jack, then we'll wrap it up and move to the next talk.
That's beautiful. So on this one, we could take the camera to the tabletop here. That's perfect, just like that. I think we're over and out. Let's go ahead and take it out. I'll show the deployed spine jack. We can take a look at the patient. So what we have here is the spine jack 5/8 as it's being deployed. As I'm turning the butterfly handle, this thing's coming up. And it's kind of like a molly bolt configuration. It's going from proximal to distal and is pulling this together. And as Neil mentioned, this is a scissor jack type of scenario of lifting force. This has 1,000 newtons of lifting force. Also, as this deploys, it's made out of one piece of laser cut titanium alloy. So the center post, as we have it in the center, we can see the aperture right here in the center where the cement comes out. So it comes out in the anterior portion of the working channel. As this is deployed, so what we do is we take this off, we'll pop this off, this whole thing, and this becomes the working channel that you inject cement through. This whole thing, proximal, no handle on this anymore. We'll inject cement through this. The aperture where the cement comes out is right here. And then once this is done, this is a collar fit, so this thing just pulls off. And so this is set on here, and I'm going to show you how we pull this off in the patient. So we're going to take K-wire, and we're going to put it through here. There's little holes in the working channel. And then I'm just going to take it, after putting it through holes in the working channel, twist, pull. Same thing on the other side. This disconnects the press fit, and the twisting motion is important. We'll separate that from the cement. And then that's it. And let's take a final AP shot here, just to see you and admire our work. And we just finished the burn. So this was we started with 13 minutes. And with explanation, with everything else, even starting to deploy, the whole procedural time for this was about just slightly over 13 minutes. And if we can take one more final view here of the elliptical burn, the radiofrequency ablation zone. This is designed as the osteocool, so this is the ablation zone in the anterior portion of the vertebral body. So this is done with a combination of 2 probes, and here we can see the color change in the chicken breast, showing and demarcating the ablation zone of the RF. So with that, we've seen different approaches to balloon kyphoplasty, transparticular, perpendicular, extrapedicular approach. We've seen balloon kyphoplasty, we've seen spine jack, and we've seen tumor ablation with osteocool, and we've also seen the Kyphon Assist. So hopefully you guys have enjoyed that, learned something from it, and we can open it up to questions and comments.
Great job.
Thank you very much, Doug. That was an excellent job on vertebral augmentation and the different approaches as well as the different technologies.
Thank you.
Thanks, man.
Any quick questions for Dr. Beall? Go ahead. So, Doug, did you hear that question, Doug?
Doug, the question was retropulsion. How do you evaluate retropulsion, and how do you make decisions on retropulsion? Well, if their mic is off, I'll answer it. Retropulsion, so the question was retropulsion. Yeah. So retropulsion was brought up by Bernice Hecker, who was the head of Noridian. And it was a concern about the behavior characteristics of the fracture and were they a risk factor. And what we found in studying it extensively is the real determination is the clinical determination, not the imaging determination. If the patient has neurologic deficit, you should not be proceeding with treating the fracture. If the patient doesn't have neurologic deficit, the retropulsion will actually improve with reduction of the fracture, but you're at risk when you insert the cement because the posterior wall is not intact. And all fluids take the path of least resistance, so you would start anteriorly and be very careful as the cement came posteriorly. So retropulsion in and of itself is not a concern. The neurologic examination is imperative. Any neurologic deficit, you should not be cementing.
So that's absolutely true. So there's a lot of misconceptions in vertebral augmentation, so listen up. So every time you have retropulsion, anytime you have a posterior bowing, that's the way the cookie crumbles. That's the way this breaks. Retropulsion exists because the interpedicular segment in the posterior portion of the vertebral body, superior third, comes back. That's how it fractures. People say, well, if there's a fracture extending to the posterior wall, you shouldn't do the case. You're too high risk. That's pish-posh. If you do something radical, like actually look at every single fracture coming through, you'll see fracture extension of the posterior wall commonly. Not the majority, but close to the majority of fractures. Oh, you shouldn't fill to the posterior third of the vertebral body. Also incorrect. In fact, you should fill to the posterior wall. You just should watch it and make sure it doesn't come. Did you see how far back I filled? All the way back to the posterior wall. Was I concerned about it extravasating? No, because I know what it looks like whenever it starts to extravasate. So, you know, there are extravasation patterns that we talk about all the time. I just wrote a whole book subsection about this, book chapter, subsegment. So fractures happen all the time to go to the posterior wall. Never a contraindication, or even a relative contraindication. You could fill to the posterior wall. Retropulsion means nothing. Do not use the word retropulsion as a surrogate or a substitute for the signs and symptoms of neurologic compromise. Never use that, because you're confusing things. Of course there's retropulsion. Any thoracolumbar junction fracture that has any degree of collapse at all will have retropulsion. That's exactly who needs augmentation. So 85-year-old thin Caucasian female, Northern European descent, T-score of minus 3.7 comes in with a T12 fracture, and the conus medullaris is tight. What are you going to do? Oh, I'm not sure we can do that. It's too much, it looks too stenotic. Okay, so I go to Neil and I say I'm too big of a sissy or don't know the literature enough to do this case. What are you going to do? As well, you know, fixture, you'd have to go 3 levels above, 3 levels below, or 2 levels. Then the time-honored tradition of the screws loosening up, even though they're cemented in place, extend further proximal and distal until she's fused from here to here. When what you should have done is try to reduce that vertebral body the maximum amount you can, have the PLL pull the fracture forward. And with devices like the spine jack I just showed you, you can absolutely do that. Open the canal by doing that. And if you take a swing and a miss, you have really hurt that 85-year-old female's chance of living till she's 90. She probably won't now at this point in time. Probably couldn't survive a spanning pedicle screw and rod augmentation. So just the knowledge about what you have to really know where your boundaries are, why you're doing what you're doing, and how to really approach each specific patient like that. So, and that's why the reason why we get so weirded out about the word retropulsion is people use that. This patient has retropulsion. Well, what does that mean? It doesn't mean anything to me. I mean, are they neurologically okay? If they're yes, go. If they're not, that's a relative contraindication.
Excellent.
Yeah.
Do you always go bilateral? Or do you unilateral echoes?
We do unilaterals all the time. I mean, I go unilateral, bilateral about 50-50. You know, if I'm able to accomplish the goal unilaterally, I'll do that. The goal is maximum height restoration, fill cement between the pedicles from end plate to end plate, and to be able to accomplish those things. If you're able to do it unilaterally, that's fine. I'm not always able to do it unilaterally. If I'm 50-50, you're going to be not 50-50, right? You're going to probably need to go bilaterally more. And people say unilateral is better because it's less invasive. That's not true. You're trying to accomplish the goal. And as we know from the U.S. registry, the complications for vertebral augmentation, to say it's safe is inaccurate. Vertebral augmentation is not safe. It's extremely safe. We had no neurologic injuries. We had, a handful of SAEs that were primarily and almost exclusively related to anesthesia, moderate sedation. And this is one of the safest things that we do, is vertebral augmentation. Exceedingly safe. Yes?
When do you choose to do?
So the last question here, guys. We have to get get the schedule going, though. Thank you. Go ahead.
Transpedicular versus extra.
So if you go perpendicular, you can.
Doug, repeat the question.
So the question is when do you choose to do transpedicular versus another approach, right? So transpedicular is usually a bilateral approach. So the spine jack is placed transpedicular. That's how it's designed to be placed. As you can see, the working channel didn't go into the posterior portion of the vertebral body. It kind of hung out in the pedicle. So if you don't go transpedicular, it's going to be loose. And you have to hold it to hold the working channel to put the implant in, which is okay, but it makes it more difficult. If you want to hit the center portion of the vertebral body for whatever reason, if you want to try to go unilaterally, if you just want to put a single balloon in, then a perpendicular is much easier to get to the center of the vertebral body. If you rock your arm using an extrapedicular or perpendicular approach, if you take that proximal needle and you want to change the trajectory and you're really you're doing the gear shift on it, you can do that with impunity. But if you have it through the pedicle and you try to rock arm this, you probably will fracture the pedicle off. And if you're not seeing that, it's probably seeing you, and you just not notice that that's the case. So if we try to get to the center of the vertebral body, one of the other approaches in transpedicular for certain devices and for a bilateral approach.
Thanks very much.